So my name is Ajay Kilanani. I am a pediatric critical care physician over at DeVos Children's Hospital in Grand Rapids, Michigan. I'm also assistant professor at Michigan State University College of Human Medicine. It's a privilege to be here, so I'm excited to talk to you guys and share ideas. As many people in this room and physician educators know, medical education has evolved significantly over the last 5 to 7 years. And really, we've gone from the traditional 2 years of basic sciences, 2 years of clinical sciences to a more integrative approach. Most of us are incorporating things like an integrated multidisciplinary curriculum into one class. We're starting to take a look at the flipped classroom where a student goes home and looks at lectures by video and then comes back to the classroom to assimilate some of those ideas. And they're getting earlier clinical experiences. So within the first 6 months of med school, they're actually starting to touch patients, which was unheard of 15 years ago. And we have our own sort of integrative curriculum just like that, which is called the Shared Discovery Program over at Michigan State. One of the interesting things I've sort of noted in most of the newer curriculums across the country is we've all left room for electives. Spaces for students to personalize some of their interests, whether it's because of their career ambitions, whether it's because they want to explore a potential passion, whether it's because they just want to get some more knowledge in an area that they may never touch again. But we've left room for those electives. One of the electives that we started at our med school was called the Pediatric ICU Bedside Medicine course. And this was basically a one credit elective. And it was for those students who wanted even more hands-on clinical exposure. It was for those who wanted extra experience with critically ill patients. And this was specifically run out of the ICU. The difference between this class and I would say most of the other classes in med school was that our objective was not for them to acquire a body of knowledge. Instead, we wanted them to learn how to think effectively. We wanted, if med school was there for them to learn how to ride a bike, we wanted them to think about how they should ride the bike effectively, efficiently, intelligently. How could they make the most out of that experience? For those reasons, our course focused on having them focus on astute and subtle observation. We had them focus on logical thinking and effective conclusion making. And we did that in a collaborative and safe situation in which all the students would do this collectively, build on each other's ideas, with the hopes that over time, as they became more experienced, as they became residents, as they gained more autonomy, they would be more empowered to make independent decisions. As an example of how this course worked, I would take 20 of you students, divide you into a group of 10 and 10. Take the first group of 10 students into a pediatric ICU room. And I would then ask you, what do you observe? The first 20 minutes of that classroom was spent just on observation, right? Art of medicine, what do you observe? What does the patient's hair look like? Is it thin? Is it present? Is it not present? What's the neural status of the patient? Are the eyes closed? Are they moving only one side extremities? Are they moving their upper extremities? Are they moving their lower extremities? Are they hypertonic? Are they hypotonic? What's the chest rise like? Are they breathing fast? Are they breathing slow? Are there retractions? Is there work of breathing? What's their perfusion like? Is their color pale? Are their nail beds pink? Are their nail beds cyanotic? All of those things collectively, the student was asked to answer those questions. And based on that, we would collectively build a set of assertions. We are worried about these things. We are not so worried about these things based on our observational exam. Now let's look at the vitals together. We look at the monitor. We look at the waveform. Can you rule out any of those conclusions that you were thinking about earlier? Do you have to rule in more conclusions? Then we would take an even deeper dive based on that and say, what examination findings do you want to think about so that you can rule in or rule out the previous conclusions that we've been discussing? And then we'd have the students evaluate the patient. And one student would say, I hear that the lungs are wet. Another student would say, I don't really think so. I think they're kind of dry. Another student would come in and listen again. And we'd sort of vote and collectively come to conclusions based on the examination findings. Again, by the end of that whole session, our collective group came up with an assessment and plan for the patient. That seems, there's nothing sort of unusual about that. A physician walks into a room and does that all the time. But how many times do we actually mentor that approach to students? But this is really hard, right? That's why I'm talking about it. And I should have known better, because when you bring a group of students first or second year into a room of an ICU patient and you say, hey, you've barely cemented your skills in taking a history and doing a physical exam, and here's a kid, not an adult, but here's a kid who has a breathing tube going into their mouth, has potentially cannulas in their nose, catheters going out of their neck, catheters going into their bladder, and now you learn, and we're going to learn collectively. And I don't mind that you're totally overwhelmed by this situation. As an educator, my job is to make sure you can learn the body of knowledge that I'm trying to teach you, but that you're in a position to learn. And that's something that I didn't anticipate. And in hindsight, it's funny, but it's not funny. But we had 3 students pass out on us in the first 2 semesters. So did I do my job to prepare them? And the answer, I think, is no. So what can we do to prepare students in this type of situation? And here's what we tried. So we tried a virtual bedside medicine situation. We acknowledged that the students weren't adequately prepared to take on early encounters at the bedside. Could we use video conferencing via secure feed, a camera at the bedside of the patient? That secure feed goes live into this conference room where I'm sitting in the room with the students, facilitating conversation. For the next 3 semesters, we tried it this way. The first class of the semester was this sort of orientation session where we did the same thing that I described to you at the bedside, except we did it in the classroom. And because we had never seen this type of orientation documented in the literature, we decided to study it. And we did a qualitative analysis, open-ended questions to the students, just to get their perspective of what were the advantages and disadvantages of this type of virtual classroom. And here's the feedback they gave us. The blue denotes the recurring themes that the students identified. The black text denotes actual quotes that they made. From an advantage perspective, they felt, hey, this was effective preparation. It was a great way to ease into the room that I don't think my peers would be able to ease into. And we could also get accustomed not only to a patient, but an ICU patient, which is a whole different level of intensity, acuity, and potentially gravity. This was really interesting. They felt that this virtual classroom was way less invasive. And I was impressed that students at this age actually thought about this stuff. When I was a student, my sort of major thought was, I want to learn, I need to learn, I have so much to learn. These students thought about, when I'm at the bedside, I'm actually concerned that I'm bothering the staff, I'm inhibiting them from doing their care, I'm emotionally disturbing the family, and with all of us students examining the child, we're actually waking this kid up more, making them more uncomfortable, and then the kid needs more sedation medications. So they found this session to be less invasive to the patient, and it actually allowed them to sit in the virtual classroom for longer. By the end of our direct encounter sessions at the bedside, I would notice a lull in the conversation. People stopped asking questions. And when you talk to the students, at some point they got to a point where they didn't feel comfortable asking more questions. But it's not because they had any. They didn't have any. In this virtual classroom, our sessions went overtime because they had more questions and they didn't feel like they needed to stop asking it because their questions weren't harming anybody. Collaborative learning. They loved the collaborative learning. That really occurred in both scenarios, at the bedside and at the virtual bedside. However, the virtual bedside had no inhibitions or sort of limitations of time. The disadvantages are very sort of easy to figure out. Obviously, take direct contact away from a person. They want direct contact. And some felt they would learn better that way. The third one, they were concerned about the limitations of the technology. Obviously, it's difficult to appreciate three-dimensional things like how bad swelling is. What's the texture of a rash? When you press a red rash, does it actually blanch and turn white, or does it just stay red? So that sort of direct contact experience is limited. The last thing I'll note here, again, is a sort of tribute to the empathy of our medical students, but they brought up concerns about the dehumanizing aspect of placing a three-dimensional patient that I would look after at the bedside, put them on a screen. All of a sudden, that patient becomes two-dimensional. They were concerned about the risk of becoming desensitized to the patient and the impacts on their own care to the patient. So that was very interesting. I think the major takeaways from this are there are advantages and disadvantages. There's a use for this, but probably not as a replacement to the direct encounters. There are many studies out there that look at teleeducation, and many of us have seen them, and many of us have talked about some of them. There are studies that look at the education of physicians. There's studies that look at the education of nurses doing wound care, but there are really limited studies looking at the impact of teleeducation and introducing bedside curriculum for medical students. So we step back and think about what's the best way to innovate in education using a technology like this. We have to ask ourselves a few questions. And as we started thinking about this process of where to go next, we started asking ourselves, what's the landscape in which we teach? The landscape for us is unique, but not that unique. There's this notion of regional medical campuses. This is not new by any means. This started in the 1950s, where main academic institutions started putting, quote, satellite or regional centers to fulfill some of the educational requirements for their students. Over the last 10 to 15 years, we've seen a huge increase in these numbers of regional centers. Again, satellites from where the main campus is. And these centers fulfill either one-year programs, two-year programs, three-year programs, or four-year medical school programs for these students. It can be only basic sciences, it can be only clinical rotations, or both. Over the last 10 years, the AAMC predicted significant shortages in physicians, and they called for med students to increase their enrollment. And we've done that over the last 12 to 15 years. Michigan State has 7 clinical rotation campuses in which we send our students to. There's obvious strengths to this type of program. The strengths are, hey, if you have a major interest in academic research in niche subspecialty areas and be exposed to those patients, you can go be at these headquarter institutions and see those patients. But if you want to be in the rural areas and you want to deal with those patients and you want to be mentored by those physicians who have been invested in those communities for the last 40 years, you can learn from them. The limitations are also there because of that diversity, though. When you have such diversity across your campuses, across the country, or across your institutions, that may lead to disparity in education, and that leaves room for something to be explored in educational models. The other thing I'll mention here very briefly is, there is an isolation component that can occur in these regional facilities as well. Isolation is talked about a lot in med school with underrepresented minorities. And the biggest concern about that is they already feel isolated in bigger centers. And that can be associated with increased academic difficulty, remediation, prolonged time in medical school, increased student debt because it took longer. And if you take students with those experiences and you put them in regional centers, would that worsen those associations? The other thing I think we had to consider, and we wanted to consider at our med school and for our curriculum, was what are the sacred relationships we are trying to retain in the new educational models that we provoke? And I would say that there's 2. This is a very familiar picture to most of us in this crowd and most of us in medicine. It's called The Doctor. It was painted in 1890. It's painted by Luke Fields. And this draws light figuratively and metaphorically to one of the most sacred relationships that we try to teach our medical students, which is the physician-patient relationship, right? And so, not surprisingly, in our educational models, we have strived to include that in all of the innovation that we do. The second relationship is not clear by this picture, but let me try to describe it to you. Imagine who your favorite teachers have been in your life. Was it a high school teacher? Was it a coach? Was it a med school teacher? Was it your parents? Was it your siblings? What did they teach you? Did they teach you how to be compassionate? Did they teach you how to think critically? Did they teach you how to think out of the box? All those people in your life made a difference and helped you to become the person you are. The teacher-student relationship is important, and especially in the context of innovating with new technologies where we see relationships start to potentially diminish. Is this something worth holding on to? And I would argue, yes, this is a sacred relationship. For the purposes of the next iteration of our sort of virtual bedside medicine, we wanted to hold on to this. We acknowledge that educational access may be limited depending on what campus you're located at. You may not get all the experiences we want you to get. So we've come up with this idea of a pilot telerounds project. And the idea is this: if you're at campus A, and I'm at the bigger center with the pediatric ICU that has 40 patients, you will still do your conventional rounds at the bedside with your attending physician. However, once you finish that, you're going to dial in to rounds at my institution. Now, it won't be the rounds that I'm doing with my residents and my medical students. It'll be a specific rounds for medical students that are located remotely. You're going to have an assigned patient. You're going to present a history You're going to do an observational exam, and we're going to learn off that patient. And then you're going to listen to other students who are also presenting the patient remotely. And it'll look something like this. I'll be at the bedside of that patient while you'll be remotely with the other students. This allows us to explore if this can play a role, an adjunctive role to your conventional education at your pediatric clerkship. And does that actually add value to your overall educational experience? It also allows us to hold on to the relationships that we perceive to be sacred, which is the physician-patient relationship, and the surrogate for that is the student-physician-patient relationship, and secondly, a new teacher that they gain remotely. The question we're obviously asking is, can we reconcile learning gaps that occur locationally and improve their overall educational experience? So what are we really talking about here with a tool like this, or many of the tools that everybody has talked about today? We're talking about parity in education, and this is a massive idea that excites people because if we can come to a point where we address learning gaps across our own institutions, across multiple institutions globally, maybe we can actually close these gaps and improve the healthcare providers' skills that we send out into the communities. And that's an access improvement, right? Populations will have improved access to healthcare. So when we talk about addressing the learning gap, our immediate reaction is to try to close the learning gap. And the most important thing I would say here is, if it's necessary. All differences don't need to be solved. All differences don't need to be reconciled. And I do this with a certain responsibility of saying, we have to maintain an attention to diversity. Diversity is important, and if we identify that the learning gap will compromise competency, that's where we should address it. Where if we feel that it doesn't hurt competency, then maybe we need to maintain personalization, diversity in curriculum, so that students with particular talents and interests can achieve that. So coming back to this question, how do we innovate in education? And the honest answer is, I have no idea. I'm no expert in this. How we've tried to do it is, in addition to thinking about curriculum and technology, we try to understand the context, identify the problem, think about what relationships in that problem are the most important to maintain attention for, because those relationships make education vibrant. Identify the gaps and close the learning gaps by empowering via educational access. And if we do that, we can actually improve healthcare. And then stop yourself for a second and respect diversity. If we don't think there are any concerns about educational gaps and the competency is already achieved, we can be happy with that. And so that's sort of my approach coming out of this project. And I think if we can do something like this, as simple as it seems, although we know it's very difficult to achieve, if we can do something like this, we're off to a great start. So thank you.
Thank you very much. Questions? Yes.
Thank you for your talk. It's a very interesting perspective. I think definitely teaching residents about different practice models, coming from, say, one small community hospital going to, a tertiary institution versus going to a large regional multi-system hospital is an integral part of preparing them for the realities of practicing medicine in those different flavors. I had a question, though, about the role in which attending physicians can play in actually preparing residents for that, because the cultures are different at those various institutions. Understanding the way in which you practice and the resources are different, and how that may how adapting to certain cultures in those different systems play out in clinical practice. So I'd love to hear your feedback.
I think that's a great question. If we all acknowledge the limitations of our own institutions, which are, hey, you're only being taught by the physicians who work here and the patients who are seen here, and if you have interest in learning what else is out there, we're not necessarily providing you that. And one of the things I think we can do with 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 just basic video conferencing technology is if you have a patient at your institution that my students wouldn't see at my institution. That also means you have teachers who are experts on that disease process that I can't teach. And if I'm okay with acknowledging that, which I should be, then I should expose them to your teachers. We should share resources, right? And vice versa. You should be able to send your patients virtually to me, or excuse me, your students, and I can expose them to my patients. And think about the collaboration we could have just from everybody in this room if we shared resources, teachers, and patients, what that would mean. And we're fortunate, in the medical community, patients and families are very open to participating in the educational process. So we have an opportunity to leverage that. And educators, I think it would be a lot easier for educators to work together across the country and something like what you're bringing up to address that problem.
Other questions? Okay, over here.
Thanks very much. That's a really innovative look at use of technology in education. I was curious if you could identify for us one location-based kind of gap that you thought needs to be closed, and perhaps one difference that you felt didn't need to be closed.
That's the second part of that question is even harder than the first, but a great question. So from my vantage point, I think the biggest thing we can accomplish from my vantage point of being a pediatric critical care physician that I can offer that is not covered in those regional centers is providing a high volume of pediatric patients with special needs that are truly critically ill. Most of our regional facilities don't have pediatric ICUs. So immediately I can provide them exposure to that. I think when you're asking about things that we cannot provide, I'm standing here talking about a sort of innovative way of teaching students remotely, but then I go into a slide but personal relationships matter. And my personal belief is that when you teach someone directly, when you talk to somebody directly, there are things a student and the interacting people are going to get out of that conversation that you cannot achieve remotely. So I see remote relationships as an adjunct to personal relationships. And to answer the second part of your question, I would say I just think there's something more comprehensive a learner can get out of a direct encounter, a direct relationship that would allow for more comprehensive learning. I don't know, what is that thing? And I don't know except to say they're a participant in that relationship in the most sort of intimate way, and I suspect it relates to that.